next speaker is Dr. Shrutakirti Parida. And the topic is clinical demographic profile and visual outcome in pediatric traumatic cataract, a prospective study. Timer to start only when speaker starts his presentation. Huh?
A very good evening to one and all. My study is titled Clinical Demographic Profile and Visual Outcomes of Pediatric Traumatic Cataract, a prospective interventional study. I have no financial interest to disclose. The objectives of this presentation are to study the clinical demographic profile of pediatric traumatic cataract in a tertiary care hospital and to find out the predictors of final visual outcomes in these patients. This was a prospective interventional study which was done from February 2022 to February 2024 in children aged 3 to 15 years who were diagnosed with traumatic cataract. All the relevant data were collected at presentation and subsequent follow-ups with a minimum of 1 year of follow-up. We did the cataract extraction with either pediatric lens aspiration using the bimanual technique or the pars plana lensectomy using the vitrector as per the case needed. And PPC plus AV was done in children who were less than 8 years with an intact posterior capsule. Postoperatively, glasses or contact lens followed by amblyopia therapy was given to the patients, and other medical and surgical management was done for other ocular morbidities wherever needed. The statistical analysis was done, and a p-value of less than 0.05 was considered to be significant. Coming to the results, the mean age at presentation was 9.37 plus minus 5.44 years, with a higher preponderance of the boys. There was secondary glaucoma reported in 6 out of the 41 eyes which were managed medically. The mean time interval elapsed between injury and cataract surgery was 4.38 plus minus 0.004 months. 9 out of the 41 eyes developed sensory strabismus, of which exotropia was most common. The mean best-corrected visual acuity at presentation was 1.5 plus minus 0.14 logMAR units, which has improved at final follow-up to 0.66 plus minus 0.03 logMAR units, which was quite good. Coming to the mode of injury, in 53.6% patients, the mode of injury was penetrating trauma, followed by blunt trauma in 38.5%. The most common objects which caused injury were stick, followed by iron rod, seizures, and broken glasses. This is the list of the associated ocular injuries in the anterior and posterior segment, which we can see. Coming to the cataract morphology, fluffy white cortical cataract followed by calcified white cataract was the most common cataract morphology. In the type of the surgical intervention, pediatric lens aspiration plus PPC, AV, and PCIOL implantation was done in 22 out of the 41 eyes, followed by corneal tear repair with pediatric lens aspiration in the first setting, followed by secondary oil implantation in the second setting after 3 to 4 months in 8 eyes, and the rest of the procedures are like this. So coming to discussion, pediatric traumatic cataract is one of the major causes of unilateral cataract. Several complications are reported after cataract surgery in the children, including PCO formation, fibrinous uveitis, IOL decentration, post-cyanic A, and potential for developing amblyopia. There are various factors which affect the visual outcome in the pediatric patients, including age at presentation, type of the injury, associated ocular injuries, time elapsed between injury and treatment, and the various treatment modalities with treatment adherence also. Majority of the children in our study were of the school-going age group. The boys were affected more than the girls because of involvement in more aggressive and violent nature of the activities, which was also at par with studies done by Goget et al., Shah et al., and Reddy et al. In our study, 56% patients showed improvement of vision at final follow-up post-operatively. In our study, children with penetrating trauma, posterior segment involved multiple surgeries due to coexisting ocular morbidities, rest intraocular pressure, poor vision at presentation, and the increased interval between injury and surgery had a poor outcome. And most of these injuries could have been prevented by adopting safety measures by children and their parents. So to conclude, penetrating trauma, posterior segment involvement, multiple surgeries, rest intraocular pressure, increased interval between injury and surgical management were the predictors of poor visual prognosis in our patients. There is a need for proper counseling of the parents and the caregivers about the importance of adoption of safety measures both at school and home. The clinic message is an ounce of prevention is always better than cure. So there is a need for the parents and caregivers to adopt the safety measures to prevent ocular trauma in the pediatric population. Thank you. These are my references.